Welcome to the Hospital Medicine Unplugged podcast. Today, we are conducting a comprehensive deep dive into a topic that often strikes a very specific chord of anxiety in the hearts of generalists and hospitalists alike: glomerulonephritis.
It is certainly a diagnosis that demands respect. I think anxiety is the right word.
It really is.
Because when we talk about glomerulonephritis or GN, we aren't discussing a single disease entity. We are entering a minefield. It's a clinical syndrome characterized by glomerular inflammation, but the presentation is just a massive spectrum.
A huge spectrum.
Yeah, on one end you have mild self-limited disease that resolves with minimal intervention, the kind where you pat the patient on the back and send them home.
Right.
But on the other end, you have these rapidly progressive forms that can destroy kidney function in a matter of days if we don't intervene urgently.
And regardless of where a patient falls on that spectrum, the stakes are undeniably high. We're seeing this across the age continuum, affecting both pediatric and adult populations.
That's right.
So, to set the baseline for our discussion today, when we say GN, we're looking for a specific cluster of hallmark features. We need to define the syndrome before we can really dissect the cause.
Precisely. We are looking for the classic nephritic picture. And this is distinct from the nephrotic syndrome, though, there's overlap, which I'm sure we'll get to.
Of course.
But the nephritic pillars are hematuria, hypertension, edema, and reduced kidney function. And despite the diverse etiologies, whether it's autoimmune, infectious, or idiopathic, they are all unified by one central event.
And what's that?
Immune-mediated injury to the glomerulus. That's the common pathway.
Okay. Before we get into the complex immunology and the new classification systems, I want to take a moment to ground us in the anatomy. We need to visualize the scene of the crime.
Good idea.
We often talk about the glomerular filtration barrier, but let's break down exactly what that entails. Why is the specific structure so prone to this type of, catastrophic failure?
It's essential to understand the anatomy, to understand the pathology. You really have to. The glomerulus is a highly specialized filtration unit. You have three key layers working in concert.
Okay, what's this first one?
First, you have the fenestrated endothelium, which lines the capillaries. These cells have pores, or fenestrae, that allow fluid and small solutes to pass, but crucially, they hold back cells.
So it's like the first sieve.
Exactly. Then second, you have the glomerular basement membrane, or GBM,
Right.
which is a negatively charged meshwork of collagen and glycoproteins. It's another barrier. And third, and perhaps most critically for our discussion, you have the podocytes.
These are the epithelial cells with those intricate interdigitating foot processes.
Correct. They are the final barrier.
Yeah.
They wrap around the capillaries and are connected by what we call slit diaphragms. This whole tri-layered structure is an engineering marvel.
It really is.
It allows the passage of an ultrafiltrate that's nearly devoid of protein, all while withstanding substantial capillary hydrostatic pressure.
And this is where the vulnerability lies.
Exactly. The podocyte is the Achilles heel of the whole system. You see, podocytes are terminally differentiated cells. They have minimal regenerative capacity.
Meaning they don't grow back.
If they're damaged or lost, the kidney can't simply grow new ones to replace them. They're kind of like neurons in that sense. Once that barrier is breached, you lose the selectivity of filtration.
And the cascade begins.
You initiate the cascade of scarring and sclerosis, what we call glomerulosclerosis, that leads to chronic kidney disease. When a podocyte detaches, that area of the GBM is laid bare to the Bowman space, and that triggers adhesions and scarring.
So we have this delicate barrier that can't repair itself well. Let's move to the pathophysiology. How does the injury actually occur? What's the mechanism driving the inflammation?
Well, the core mechanism is immune-mediated inflammation. This involves antibody deposition, complement activation, and the infiltration of inflammatory cells right into that delicate glomerular space. It's a case of biological friendly fire.
Friendly fire. I like that analogy.
If we look at a classic example, like post-streptococcal GN, the pathogenesis is multifactorial.
This is the classic Coca-Cola urine after a sore throat scenario we all learned about.
That's the clinical presentation, yes. But molecularly, what's happening is the formation of immune complexes. These can be circulating immune complexes that form in the blood and then get physically trapped in the glomerulus just due to the filtration dynamics.
Okay, so they're just passing through and get stuck.
Right. Or, and this is a key concept, they can be formed in situ.
Meaning the antigen is already in the kidney.
Exactly. We call it the planted antigen theory. We see molecular mimicry or specific bacterial proteins literally planting themselves in the glomerular tissue.
Can you give an example of that?
Sure. In post-streptococcal GN, we've identified specific nephritogens, such as the nephritis-associated plasmin receptor and streptococcal pyrogenic exotoxin B.
So these bacterial proteins, the nephritis-associated plasmin receptor and the exotoxin B, they actually lodge themselves in the glomerulus.
Yes. They act as a deacon. The antibodies find them there, they bind to them, and form the immune complex right on the glomerular basement membrane.
And that's the trigger.
That's the trigger.
Yeah.
These complexes then activate the complement cascade. This leads to the recruitment of neutrophils and other inflammatory mediators. You get a swarm of inflammatory cells releasing enzymes and oxidants, causing direct damage to that beautiful three-layered barrier.
And this inflammation leads to the clinical consequences we see at the bedside. Let's connect the physiology to the symptoms. Why does the GFR drop so suddenly in these patients?
It's really a mechanical issue created by the inflammation. The capillary lumens physically narrow.
They get clogged.
They get clogged. You have endocapillary proliferation, an increase in endothelial and mesangial cells within the capillary loops, along with that massive infiltration of neutrophils we just mentioned. This chokes off the blood flow. It physically reduces the surface area available for filtration.
So the plumbing is blocked.
Effectively, yes.
Yeah.
And that drop in GFR explains the volume status.
Right. The hematuria comes directly from the capillary wall damage. The barrier's broken, red blood cells are leaking out, but the edema and the hypertension.
That is largely due to sodium and water retention.
Yeah.
Because the GFR has plummeted, the kidney just cannot excrete the daily load of salt and water. It holds on to it.
So it's a volume problem.
That's a volume problem. And it's important to distinguish this from nephrotic syndrome, where edema is often attributed to hypoalbuminemia and reduced oncotic pressure.
In acute nephritic syndrome, the albumin might be normal or only slightly low. This is a volume retention state due to primary renal failure. The tank is full because the drain is clogged.
That distinction is so vital for management, which we'll get to later. But first, I want to discuss a major shift in how we think about these diseases. Historically, we used to classify GN based on patterns we saw under the microscope, terms like membranoproliferative or diffuse proliferative.
We did. We used terms describing the pattern of injury, but modern nephrology has moved, or is, still moving away from that traditional pattern-based classification toward a pathogenesis-based approach.
And why is that?
Because the pattern is just the reaction of the kidney to the injury. It doesn't tell you the cause. We now categorize these diseases based on the underlying immunologic mechanism driving the injury.
And this is largely driven by what we see on immunofluorescence, or IF.
Correct. Immunosluorescence is a classifier. It tells us what proteins are depositing in the kidney. We generally group them into 5 major pathogenic categories. The first is immune complex GN.
Okay, this would be the group characterized by granular deposits, right?
Yes, granular deposits of polyclonal immunoglobulin. It looks like a starry sky on the slide. This category includes your post-infectious etiologies, post-streptococcal, staphylococcal, viral. It also includes IgA nephropathy, lupus nephritis, and membranoproliferative GN, or MPGN.
A lot of heavy hitters in that group.
Yes, a very common group.
Then we have the second category, which is defined by what you don't see.
Precisely. The pouchy immune GN, pouchy meaning few or little. On immunofluorescence, you see minimal immunoglobulin or complement deposition. The slide is essentially black.
And what does that tell you? It tells you that this is the hallmark of ANCA-associated vasculitis. The damage here is driven by T cells and cytokine activation of neutrophils, not by antibody deposition in the tissue itself.
Very different mechanism.
Completely.
The third category has a very distinct look on IF.
That would be anti-GBM, GN. Here you see this beautiful linear IgG staining along the glomerular basement membrane. It looks like a smooth ribbon outlining the capillaries.
And that's what we see in Goodpasture syndrome.
Characteristic of Goodpasture syndrome. The antibody is targeting the collagen in the basement membrane directly.
And the remaining 2 categories.
We have monoclonal immunoglobulin GN, which is related to dysproteinemias like myeloma or amyloidosis. And finally, the 5th category is C3 glomerulopathy. This is a relatively newer concept where you see bright C3 staining with minimal or no immunoglobulin.
This distinction, C3 without immunoglobulin, is critical.
It is the defining feature. It tells you that the problem isn't an antibody attacking something. The problem is a dysregulation of the complement system itself, specifically the alternative pathway. The bomb squad, so to speak, is detonating without a target.
That's a great way to put it.
And this shift in thinking from, say, MPGN to C3 glomerulopathy has completely changed how we work up and treat these patients.
This pathogenesis-based framework is so much more useful because it points us directly toward the treatment. If it's antibodies, we remove them or stop their production. If it's complement, we inhibit complement.
Exactly.
Now let's talk about who is actually getting these diseases. The demographics are shifting.
They are. They really are. If we look at post-streptococcal GN, historically this has been a disease of children, predominantly aged 2 to 10 years, with a slight male predominance. It's rare under age 2 and rare over age 40.
And there's a geographic divide as well, isn't there?
A significant one. The incidence is much higher in developing countries, about 24 per 100,000, compared to developed countries where it's around 6 per 100,000.
But the trend in developed nations is changing.
Yes, it is. We're seeing a decline in post-streptococcal GN in children, likely due to better skin and throat hygiene and widespread antibiotic access for streptococcal pharyngitis. However, we're seeing an increase in infection-related GN in adults.
And in adults, the culprit is often not strep.
Correct. In adults, especially the elderly and those with diabetes, we're seeing more staphylococcal infection-related GN. You need to think about your patient with a diabetic foot ulcer or an infected central line or a joint infection.
So, Staph aureus.
Staphylococcus aureus is a major player here, and it presents differently, often more insidiously, and has a much worse prognosis than the childhood post-strep variety.
What about IgA nephropathy? That's the other big player.
IgA nephropathy is the most common primary glomerular disease worldwide. It tends to hit young adults, with a mean age of onset between 34 and 45. There's a strong genetic component, with the highest incidence seen in East Asian populations.
And in the U.S.?
In the U.S. alone, it affects roughly 200,000 people. It's the most likely cause of GN in a young male presenting with hematuria.
Moving from the population level down to the individual patient in the emergency department or the clinic? We mentioned the classic features, but let's drill down into the clinical presentation. We call it the nephritic syndrome.
We do. And as we touched on, there are 4 pillars you need to identify. First, macroscopic hematuria. Patients will describe tea-colored or cola-colored urine. That color comes from the oxidation of hemoglobin in the acidic urine.
And second?
Second, edema. This typically starts periorbitally puffiness around the eyes in the morning and then progresses to dependent edema in the legs.
Why periorbital specifically? What's the mechanism there?
It's because the tissue pressure around the eyes is low. When you're lying flat at night, that retained fluid redistributes. It settles in the path of least resistance, which is that loose tissue.
Makes sense. And the third and fourth pillars?
Third is hypertension, often new onset and often quite severe. And fourth is oliguria, or decreased urine output.
Is this presentation consistent across age groups, or does it look different in kids?
It's fairly consistent, though the frequency of symptoms can vary. A study in pediatric patients found that edema was present in about 93% of cases, hypertension in 87%, and gross hematuria in roughly 67%.
So if a child comes in puffy and hypertensive, even if the urine looks clear to the naked eye?
You have to dip it. Absolutely. You cannot rely on the parents reporting red urine.
One of the most helpful clinical clues is the timing. The latency period between an infection and the onset of kidney symptoms can really help distinguish the etiology.
This is a critical board pearl and a clinical pearl. It's so important. In post-streptococcal GN, there is a distinct latency period. Symptoms develop anywhere from 7 days to 12 weeks after the infection.
So there's a lag.
A definite lag.
Yeah.
It takes time for the antibody titers to rise and the immune complexes to form. If a child has a sore throat on Monday and hematuria on Tuesday, that is almost certainly not post-streptococcal GN.
Whereas in IgA nephropathy, the timing is much tighter.
Exactly. We call it synphryngitic hematuria, syn meaning with. The hematuria occurs concurrently with the upper respiratory infection. A young adult gets a cold, and within 24 to 48 hours, they have visible blood in their urine. That is classic IgA.
So what's happening there?
It represents a flaring of the mucosal immune system that immediately spills over into the kidney.
It's also worth noting that many cases of IgA, up to 60%, are detected incidentally.
Yes, very true. Often during a routine physical for insurance or sports, when microscopic hematuria or proteinuria is found in an otherwise asymptomatic person. This silent presentation is dangerous because the damage can accumulate over years before it's noticed.
When we're examining these patients, aside from the edema, what else are we looking for?
You need to assess for fluid overload carefully. Check for jugular venous distension. Listen for pulmonary crackles. Remember, pulmonary edema is a common complication.
Okay.
But you also need to be a detective for systemic diseases. Look for a malar rash or arthritis that might suggest lupus. Look for palpable purpura on the lower extremities, which is a hallmark of vasculitis, specifically IgA vasculitis.
What used to be called Hanochian line purpura.
Exactly. Or it could be ANCA vasculitis. The skin can give you big clues.
So once we have the clinical suspicion, we turn to the laboratory. We're the laboratory detectives now, and it starts with the urinalysis.
The urinalysis is the liquid biopsy. It provides an incredible amount of information if you know how to look. The pathognomonic finding we are hunting for is the red blood cell cast.
Explain the mechanism of the cast. How does it actually form?
Well, when red blood cells squeeze through that damaged glomerular filter, they enter the renal tubule. In the distal tubule, there's a protein called Tam-Horsfall protein, or uromodulin, which is secreted by the tubular cells.
Okay.
In the setting of stasis, or concentrated urine, the red blood cells get trapped in this gel matrix, and they get molded into the shape of the tubule like jello, in a mold.
So when that gel is flushed out,
You see a cylindrical cast, packed with red cells. It's the proof. It proves the bleeding is coming from the nephron, not the ureter or bladder.
and we look for dysmorphic red blood cells as well.
Yes, red cells that have passed through the high osmolar environment of the tubule and squeezed through the glomerular gaps get beaten up. They look misshapen, they have blebs, we call them acanthocytes.
And the protein.
We also check for proteinuria. In nephritic syndrome, proteinuria is typically mild to moderate, usually less than 3.5 grams per day. This contrasts with nephrotic syndrome, where massive proteinuria is the defining feature.
Now, for the high-yield diagnostic algorithm, the complement levels, this is something that often trips people up, but it's incredibly useful for narrowing the differential.
It is the most efficient way to sort through the possibilities. It really is. You want to check C3 and C4 levels. We can break it down into 3 patterns based on which pathway is activated.
Let's take the first pattern. Low C3 and low C4, both are consumed.
Okay, when both are consumed, it suggests the classical pathway is activated. The classical pathway uses both C3 and C4. This points you toward immune complex-mediated diseases like lupus nephritis, cryoglobulinemia, or rare forms of classical pathway-mediated MPGN.
To think systemic autoimmune processes.
Exactly, where large immune complexes are consuming everything.
Okay, pattern number 2. Low C3, but normal C4.
This indicates activation of the alternative pathway. The alternative pathway consumes C3, but bypasses C4. This is the classic profile for post-infectious GN. It's also seen in C3 glomerulopathy and hemolytic uremic syndrome.
And there's a time factor here for the post-infectious cases, right?
A crucial point. In post-streptococcal GN, the C3 is consumed during the acute phase, but it should normalize as the infection clears and the immune complexes clear. It typically normalizes within 6 to 8 weeks.
And if it doesn't?
If you have a patient where the C3 remains persistently low beyond 8 weeks, you need to rethink your diagnosis. It's likely not post-strep. You should start considering MPGN or C3 glomerulopathy. That's a huge clinical branch point.
And finally, the third pattern, normal complement.
If both C3 and C4 are normal, you're looking at diseases that do not consume complement in the serum. This includes IgA nephropathy, ANCA-associated vasculitis, and anti-GBM disease.
So just by ordering C3 and C4, you've split your differential into 3 manageable buckets. From there, we send serologies to confirm.
Yes, you order the specific test based on your complement roadmap. ASO titers and anti-DNase B if you suspect post-strep, ANA and anti-dsDNA for lupus, ANCA and anti-GBM antibodies if complement is normal.
And what about for older patients?
In patients over 50, please do not forget to rule out monoclonal gammopathies with serum and urine protein, electrophoresis, and free light chains. Monoclonal immunoglobulin GN can mimic many other patterns.
What about imaging? We usually get a renal ultrasound. What's its role?
The ultrasound is primarily to rule out obstructive causes of renal failure and to check kidney size and echogenicity. In acute GN, the kidneys are usually normal in size or even slightly enlarged due to inflammation and edema.
And if they're small?
If you see small, shrunken, echogenic kidneys with a thin cortex that suggests chronic irreversible disease, that's scarring. In that case, aggressive immunosuppression might not be warranted because the damage is already done.
The ultimate question in nephrology is always, to biopsy or not to biopsy? Do we stick a needle in everyone?
We do not. We have specific indications. We biopsy if the etiology is unclear, if the disease is severe or rapidly progressive, if there's significant renal dysfunction, or if an adult presents with nephrotic range proteinuria.
But there are notable exceptions where we hold off.
The biggest exception is children. A child presenting with classic post-streptococcal GN pharyngitis history, hematuria, low C3, does not need a biopsy. The diagnosis is clinical, the prognosis is good, and the management is supportive. We spare them the invasive procedure.
Any others?
We also typically don't biopsy children under 12 with steroid-sensitive nephrotic syndrome initially.
But if we do biopsy, we're looking at three things: light microscopy, immunofluorescence, and electron microscopy. Let's paint the picture of what we see.
On light microscopy, for post-infectious GN, we see a diffuse proliferative pattern. The glomerulus is hypercellular. It's packed with neutrophils. We call it exudative because it looks like an abscess inside the glomerulus.
And what's the most worrisome finding on light microscopy?
Crescents.
Crescents are a red flag.
Yeah.
Describe what a crescent actually is.
A crescent is formed when the capillary wall ruptures. Plasma proteins, specifically fibrin, leak out into the Bowman space. This fibrin stimulates the proliferation of parietal epithelial cells and the infiltration of macrophages. They fill up Bowman space, crushing the glomerular tuft. It looks like a crescent moon on the slide.
So it's essentially a scar in the making that is actively crushing the filter.
Yes, it indicates severe glomerular injury and a break in the Bowman's capsule. If you see crescents, it implies rapidly progressive glomerulonephritis, or RPGN.
And that's an emergency.
It usually demands urgent aggressive treatment because those crescents will turn into fibrous scar tissue very quickly. And interestingly, crescents are more common in adult staphylococcal-associated GN than in classic post-strep.
We already discussed the IF patterns, granular, linear, pouchy immune. What about electron microscopy? This gets us down to the nanometer level.
EM gives us the ultrastructural detail. The classic finding in post-streptococcal GN is subepithelial hump-shaped deposits. They look like camel humps sitting on the epithelial side of the basement membrane, right under the podocytes. These are those large immune complexes we talked about.
And for IgA?
In IgA nephropathy, the deposits are found in the mesangium, the central stalk of the glomerulus.
We've alluded to the difference between nephritic and nephrotic syndrome. It's often taught as a binary choice, but real life is messier.
It's a spectrum with significant overlap. Classically, nephritic syndrome is inflammation. Hematuria, RBC casts, hypertension, oliguria, and non-nephrotic proteinuria.
And nephrotic?
Nephrotic syndrome is about permeability. Massive proteinuria defined as greater than 3.5 grams per 1.7, 3 meters squared per day, leading to hypoalbuminemia, edema, and hyperlipidemia.
But patients can read the textbook and decide to do both.
Exactly. You can have nephrotic syndrome with nephritic features, or vice versa. Some diseases, like MPGN or lupus, frequently present with a mixed picture. You might have nephrotic range proteinuria, but also have active urinary sediment with RBC casts. This implies you have both podocyte injury causing the leak and inflammation causing the bleeding.
And of course, in any patient with hematuria, you must rule out non-glomerular causes like UTIs, kidney stones, malignancy, or trauma before you go down the GN rabbit hole.
Absolutely. A patient with a kidney stone and a UTI can have hematuria and flank pain. You need to look for the casts and the protein to anchor you to the parenchyma.
Let's shift gears to management. We've made the diagnosis. Now, how do we treat it? It seems to start with supportive care for everyone.
Supportive care is the cornerstone. It absolutely is. Regardless of the cause, you must manage the consequences of the renal failure. First, blood pressure control. We target a systolic BP of 120 or less. The agents of choice are ACE inhibitors or ARBs.
Why specifically ACEs or ARBs?
Because they do double duty. They lower systemic blood pressure, but they also preferentially dilate the efferent arteriole of the glomerulus. This reduces the intraglomerular pressure, the pressure inside the filter itself.
Ah, so it's a direct mechanical effect on the glomerulus.
Yes. By lowering that pressure, you reduce the mechanical stress on the podocytes and reduce proteinuria. They're antiproteinuric drugs as much as they are antihypertensives.
And volume management.
Critical. Sodium restriction to less than 2 grams per day is mandatory. And we use loop diuretics, often in high doses, to manage the edema and volume overload. Remember, this is a volume-dependent hypertension. Vasodilators won't work well if the tank is still overfilled.
Now, for the specific etiologies, let's start with post-infectious GN.
For classic post-streptococcal GN, the treatment is primarily supportive. We manage the BP and the fluid. We only use antibiotics if there is still an active infection present like strep throat or impetigo to prevent spread to others. We do not use immunosuppression.
And the prognosis?
Most cases will resolve spontaneously, with a massive diuresis occurring within 1 to 2 weeks.
So it's a waiting game.
It is. The creatinine usually returns to baseline within 4 weeks.
What about IgA nephropathy? This is an area that has seen an explosion of new therapies recently. It used to be watch and wait, but that has changed.
It really has. For a long time, we had very little to offer besides ACE inhibitors. Now, for patients at high risk of progression, generally defined as having proteinuria greater than 0.5 to 1 gram per day, despite maximal supportive care, we have options.
One of the biggest game changers has been a targeted steroid.
Yes, targeted release budesonide. The dose is 16 milligrams per day for 9 months. The genius of this drug is its delivery mechanism. It's designed to release the drug in the distal ileum, specifically targeting the Peyer's patches.
And why target Peyer's patches? What's the connection?
Because that is where the pathogenic galactose-deficient IgA1 is produced. We now understand that IgA nephropathy is actually a disease of the gut-kidney axis.
The gut-kidney axis.
The mucosal immune system in the gut is hyperactive and producing this bad IgA. By targeting the source of the antibody production in the gut, we can reduce the circulating levels of the pathogenic IgA that end up depositing in the kidney.
And you minimize systemic side effects.
You minimize systemic steroid side effects while hitting the disease at its origin.
So we're treating the gut to save the kidney.
Precisely.
And we have SGLT2 inhibitors now playing a role here too.
Absolutely. SGLT2 inhibitors are now standard of care for nephroprotection in IgA nephropathy, just as they are in diabetic kidney disease. They reduce intraglomerular pressure through tubuloglomerular feedback and have been shown to slow the decline of GFR significantly.
There are also some brand new agents hitting the market.
There are. We have iptacopan, which is a complement inhibitor. It specifically blocks factor B in the alternative pathway. And we have sparsentan, which is a dual antagonist. It blocks both endothelin receptors and angiotensin receptors.
And what's the thinking behind that?
Endothelin is a potent vasoconstrictor and a driver of fibrosis. By blocking it, we get added protection against scarring. It's a very exciting time for IgA management.
If targeted budesonide isn't available, do we use systemic steroids?
We do, but with caution due to the toxicity profile. The testing trial showed benefit in reducing proteinuria and kidney failure, but it also showed high rates of adverse events like serious infections. So we use lower doses now if we have to use systemic prednisone, and we add prophylaxis for things like PCP pneumonia and gastric ulcers.
Now let's talk about the scary stuff. Rapidly progressive glomerulonephritis, or RPGN, the patients with crescents.
This is a medical emergency. Time is nephrons is the mantra here. If you suspect RPGN, you cannot wait for the biopsy result to start thinking about the plan.
So what's the first step?
The standard approach has been high-dose IV methylprednisolone pulse steroids, typically 1,000 milligrams daily for 3 days, followed by oral prednisone and an agent like cyclophosphamide or rituximab.
There's been some update on the steroid dosing here, right? We're moving away from the massive doses.
Yes, the Pixavast trial in NCA vasculitis was a landmark study. It showed us that a reduced-dose rapid steroid taper is just as effective as the traditional high-dose regimen, but with significantly fewer infectious complications.
So safer with the same efficacy.
Exactly. So we are learning that we can perhaps be a little gentler with the steroids without sacrificing efficacy. We still pulse initially,
Right.
but we taper faster.
And for ANCA-associated vasculitis specifically, rituximab or cyclophosphamide.
Rituximab has largely become the agent of choice. It's a monoclonal antibody against CD20 on B cells. It is non-inferior to cyclophosphamide for induction and is superior for patients with PR3A&CA disease or relapsing disease.
So cyclophosphamide is used less now.
It is still used, especially in very severe cases or where rituximab is not available, but it carries those long-term risks of infertility and bladder toxicity.
What about anti-GBM disease? Good pastures.
That requires plasma exchange. Because the antibody is pathogenic and circulating in high titers, you have to physically remove it from the blood. We do plasmapheresis daily for 2 to 3 weeks, in addition to giving cyclophosphamide and steroids to stop the production of new antibodies.
And the prognosis there depends heavily on how they present.
It does. It is very unforgiving. If a patient with anti-GBM presents already dialysis-dependent with 100% crescents on biopsy, the chance of renal recovery is extremely low. The damage is often irreversible by the time they hit the door.
Which underscores why early detection of hematuria is so important.
So important.
Speaking of prognosis, let's look at the long-term outlook for these patients, starting with the kids with post-strep.
The prognosis for children with post-streptococcal GN is generally excellent. The vast majority, over 95%, recover completely. Hematuria usually resolves within 6 months. Mild proteinuria can persist for a couple of years, but chronic renal insufficiency is rare, occurring in maybe 0 to 20% of cases depending on the series.
But there's a caveat emerging from the data.
There is. Long-term epidemiological data suggests that even after complete remission, having had childhood PSGN is a risk factor for developing chronic kidney disease later in life.
So recovered might not mean completely back to baseline.
It raises the question of whether the kidney retains a subclinical scar or a reduction in nephron mass that makes it more vulnerable to aging and hypertension decades down the line. We should probably be monitoring these recovered patients more closely.
And adults with infection-related GN don't fare as well.
No, they do not, especially the elderly or those with staph infections. They have higher mortality and higher rates of non-recovery of kidney function. Often the infection is ongoing at the time of diagnosis, like endocarditis or osteomyelitis, which complicates the management. The kidneys take a back seat to keeping the patient alive from sepsis.
And IgA nephropathy. It was often called benign hematuria in older texts, but that's a misnomer.
It is absolutely a misnomer. IgA nephropathy is a progressive disease. Up to 50% of patients will develop kidney failure requiring dialysis or transplant within 10 to 20 years of diagnosis. It's a slow burn, but it burns.
What are the predictors of a bad outcome in IgA?
We use the MESTC score from the biopsy, but clinically. Hypertension, significant proteinuria, specifically greater than 1 gram per day, and a reduced eGFR at the time of diagnosis are bad signs.
This also brings us to an important genetic factor we need to mention, APO1.
Right, the APO1 gene variants. This is crucial for risk stratification.
Do you explain that?
We know that variants in the APO1 gene, which are common in individuals of West African ancestry because they offer protection against African sleeping sickness, are a major risk factor. Having 2 risk alleles significantly increases the risk of progression in many kidney diseases, including GN.
So it's a genetic predisposition.
Yes, and in the setting of inflammation like lupus or HIV or even COVID, these APO1 variants can trigger podocyte injury and rapid collapse of the glomerulus. It's a second hit hypothesis. The GN provides the inflammation, and the APO1 genotype makes the podocytes fragile.
And C3 glomerulopathy.
Generally a poor prognosis. The median kidney survival is only about 91 months, so less than 8 years. High creatinine and extensive damage on biopsy predict faster progression. Because the driver is a genetic or acquired defect in the complement system itself, it's very hard to turn off without specific inhibitors.
And we must also manage the acute complications while we're treating the underlying disease.
Absolutely. AKI requiring dialysis is the most obvious one. But pulmonary edema is the most common severe complication in children. You have to be aggressive with diuretics.
And what else?
Hypertensive emergencies can occur. Seizures, posterior reversible encephalopathy syndrome, or PRES, and hyperkalemia is a constant threat in the acute phase due to oliguria.
Let's do a recap of the emerging research and the board pearls before we close. The field is moving toward complement inhibition.
Yes. We mentioned iptacopan. We also have eculizumab, a C5 inhibitor, showing promise in C3 glomerulopathy and atypical HUS. The complement system is the new frontier for targeted therapy in nephrology. We're moving from blunt immunosuppression to surgical strikes on specific pathways.
Okay, let's do a rapid-fire exchange of the absolute must-know pearls for anyone taking care of these patients or sitting for boards. I'll give you the cue, you give the pearl.
Ready?
RBC casts on urinalysis.
Pathognomonic for glomerular bleeding. It rules out the lower tract.
Tea-colored urine in a child.
Classic for post-streptococcal GN. Look for the strep history.
Low complement levels.
Narrows the differential to 3 things: post-infectious, lupus, or MPGN cryoglobulinemia.
Persistently low C3 for more than 8 weeks.
Stop thinking post-strep. Think lupus or a C3 glomerulopathy.
Synpharyngitic hematuria blood in urine with the cold.
IgA nephropathy.
Presence on biopsy.
Severe disease, RPGN, requires urgent immunosuppression to save the kidney.
To wrap up this deep dive, we've journeyed from the molecular mechanisms of inflammation through the diagnostic maze and into the modern era of targeted therapy.
The key takeaway is that we're no longer just looking at patterns. We're looking at pathogenesis. Whether it's granular immune complexes, linear anti-GBM, or post-immune vasculitis, the mechanism dictates the treatment. We aren't just treating GN anymore. We're treating galactose-deficient IgA or alternative pathway dysregulation.
And while some forms, like post-strep in kids, are usually benign and self-limited, others, like RPGN, are emergencies where every hour counts. We've moved from watch and wait to sophisticated biologic agents that target the gut immune system or specific complement factors.
It's a remarkable evolution, and it underscores the importance of the initial workup. That simple urinalysis and complement panel can set you on the path to saving a kidney. Don't blow off the hematuria.
I want to leave our listeners with a final provocative thought. We mentioned the link between childhood GN and adult CKD.
Yes. It challenges our definition of recovery. If a childhood infection leaves a subclinical scar that manifests as kidney failure 40 years later, are we missing a huge window for prevention?
That's a powerful question.
Perhaps we need to view the kidney's health timeline not in weeks or months, but in decades. It begs the question, is there really such a thing as a fully benign acute kidney injury, or is every hit a withdrawal from a finite bank of nephrons?
Something to mull over. Thank you for joining us on this deep dive into glomerulonephritis.
Our pleasure.
Until next time, this is Hospital Medicine Unplugged.